Hello, I'm Professor Emily Mercuri, and this is Chapter 23, Endocrine System Drugs in Essentials of Pharmacology for Health Professions, 9th edition. Chapter Objectives. Upon completion of this chapter, the learner should be able to identify the hormones secreted by these four endocrine glands: pituitary, adrenals, thyroid, and pancreas. Describe the various conditions that can be treated with corticosteroids. Explain the proper administration of corticosteroid therapy. List serious potential side effects of long-term steroid therapy. Describe medications given for hypothyroidism and hyperthyroidism and their side effects. Identify the symptoms of hypoglycemia and hyperglycemia and appropriate interventions. Explain the uses and side effects of oral and injectable non-insulin anti-diabetics. Compare and contrast insulins according to their action: rapid, intermediate, and long-acting, naming the onset, peak, and duration of each category. The four endocrine glands. When we're talking about the endocrine system, it is similar to the nervous system in that it can be thought of as a body control system. However, with the nervous system, there are these kind of fast reactions and changes based on either internal or external stimuli, whereas the endocrine system is going to exert its effects over a longer period of time. Endo means within, and endocrine refers to an internal secretion of hormones produced by one of these four glands. These hormones and other substances created by the glands are responsible for the function of the body's cells and organs. The four categories we'll be discussing and the hormones they produce include the pituitary gland, somatotropin and adrenocorticotropic hormones, the adrenal glands, corticosteroids, thyroid produces thyroxine and triiodothyronine, and the pancreas, which produces insulin. Endocrine system drugs. When we are giving drugs or medications for the endocrine system, there are two broad categories. The first one is natural hormone drugs. These are secreted by the body's ductless glands directly into the bloodstream. So what natural hormone drugs are, they are derived from natural sources and oftentimes act exactly as the hormone itself would in the bloodstream, because it is a natural hormone production that is then utilized to provide therapy to someone who's not creating enough of that hormone. The four categories we will be talking about are pituitary hormones, adrenal hormones, thyroid agents, and anti-diabetic agents. The other broad category is synthetic hormone drugs. Synthetic, as the name implies, are created in a lab, and they are substitutes for a natural hormone, and they are used to treat hormonal imbalances, much in the same way, but oftentimes they'll work a little bit differently because they are synthetically created. Pituitary hormones. The pituitary gland is known as the master gland due to its important functions in controlling body systems, as well as the effect it has over the other glands within the endocrine system. So you will see that sometimes the pituitary hormones that are released are kind of controlling the other glands and telling them what to produce. So I think of it as the mastermind of the endocrine system. Hormones secreted from this gland include somatotropin, also known as growth hormone, and that regulates growth and metabolism as well as body composition. Adrenocorticotropic hormone, ACTH, which stimulates the adrenal glands to produce cortisol and other hormones. Thyroid stimulating hormone stimulates the thyroid gland to produce thyroid hormones. Gonadotropic hormones, FSH, follicle stimulating hormone, LH, luteinizing hormone, and LTH, luteotropic hormone, also known as prolactin. So FSH, follicle stimulating hormone, that works on stimulating follicle development of the reproductive organs in biological females, and then sperm production in biological males. luteinizing hormone involved in stimulating ovulation in biological females and testosterone production in biological males. And LTH, otherwise known as prolactin, stimulates the mammary glands to produce milk. Oxytocin is another pituitary hormone, comes from the posterior pituitary. This plays a role in childbirth, lactation, and social bonding. And vasopressin, antidiuretic hormone, which regulates water balance by controlling kidney reabsorption of water. Knowledge check. Which hormone is secreted by the kidneys? We did not talk about which hormones are secreted by the kidneys at this point, but 3 of these can be eliminated based on the fact that they are all from the pituitary gland. So A, prolactin, B, oxytocin, C, erythropoietin, and D, ACTH. The answer is C, erythropoietin. I want you to be aware that the endocrine system and these 4 glands are the primary system that works with hormones and other things within the body that are controlled by hormones. But there are organs that are part of other systems that do produce hormones and are part of this overall function. So that's why when we talk about the kidneys, it's not one of those 4 glands, although the adrenals sit right above the kidneys, but it does produce its own hormones, and it is a part of this overall function of hormonal activity within the body. So let's move on to adrenal corticosteroids. The purpose of corticosteroids, supportive, not curative. So think about it this way. Corticosteroids are secreted by the adrenal glands, which again sit right on top of the kidneys, and act on the immune system to suppress the body's response to infection or trauma. So by suppressing the body's response to infection or trauma, they relieve inflammation, reduce swelling, and suppress symptoms in acute conditions. So let's say that you had a really bad infection and your body was kind of rushing all of these immune factors to that area of your body, and it's causing a lot of swelling, a lot of pain. It can actually create a ripple effect where the problem is getting worse based on all the inflammation and swelling. The corticosteroids are going to work to suppress that response. Ultimately, we don't want to suppress our immune systems long term, but in the short term, it suppresses that swelling and supports the immediate goal, but it doesn't actually cure the problem. That's why we think of it as supportive, not curative. Some conditions that can be treated with corticosteroids: allergic reactions. An allergic reaction is basically your body's immune system having an inappropriate over-response to an allergen. Think about if you've ever seen somebody or heard of somebody with a peanut allergy. Their body is telling them, this is attacking me, this is a bad thing, it's going to lead to swelling, it's going to lead to all these immune factors kind of trying to kick up this response that could ultimately swell the throat shut. So those steroids will help kick all of that inflammation down. Acute flare-ups of rheumatic or collagen disorders, so autoimmune disorders. Acute flare-ups of severe skin conditions such as eczema. Acute respiratory disorders where there's inflammation, swelling in the lungs. And long-term prevention of severe persistent symptoms of asthma or chronic obstructive pulmonary disorder, which both of those cause this inflammation in the lungs tissue. Malignancies, such as cancer, to kind of slow down the spread and the immunoresponse. Cerebral edema, which is swelling of the brain, again, can help control that inflammation. Organ transplant. The reason that we would be given an organ transplant is your body will oftentimes view a organ that is donated as a foreign invader and start to attack it. So we want people to have a suppressed immune response right following an organ transplant so that their body's not attacking that new organ. Life-threatening shock, which leads to swelling in the tissues outside of the vascular space, and acute flare-ups of ulcerative colitis, which is intestinal inflammation disorder. Side effects of adrenal corticosteroids: adrenocortical insufficiency and atrophy. So sometimes what happens is when we put this exogenous or external source of hormone into our body, our own glands and system can say, oh, there's already enough of this. I'm not going to make more. And or I can kind of shut down in making this hormone. And so insufficiency would mean that your own glands are now not producing enough, or the gland itself starts to shrink and atrophy. Delayed wound healing and increased susceptibility to infection because we've kicked down that immune response. Fluid and electrolyte imbalance, possibly resulting in edema, hypertension, and heart failure. Muscle pain or weakness. Osteoporosis with fractures, especially in older women. Stunting of growth in children. Cushing syndrome. Cushing syndrome, it is a disorder where there is obesity of the central trunk, this kind of very circular appearance to the face known as a moon face. Acne, hirsutism, which is excessive hair growth. Amenorrhea, or a lack of a period, and hyperglycemia. So this is a result of this kind of chronic use of hormones, because these corticosteroids actually kick up cortisol, which is a stress hormone, and that is what leads to these Cushing symptoms, the Cushing syndrome as a whole. Gastric or esophageal irritation, ulceration, or hemorrhage. Central nervous system effects, headache, vertigo, insomnia, euphoria, and anxiety. Petechiae, easy bruising and skin thinning and tearing. And then increased blood sugar or fluctuating blood sugar levels. And all of those have to do with that cortisol within the body. Contraindications, long-term use. These should only be used short-term. Viral or bacterial infections and fungal infections can be a contraindication because, again, they can cause that to spread more if it's going to, we only use it in that case in a life-threatening situation, as well as the appropriate anti-infectives, antibiotics, etc. Hypothyroidism or cirrhosis. People with these conditions can have an exaggerated response to corticosteroids. Hypertension or heart failure. Patients with psychosis or emotional instability because we don't want to impact their cortisol or stress hormone levels. Diabetes, because it can increase blood sugar. Glaucoma. The drugs may increase the intraocular pressure, which glaucoma is when there's too high of pressure within the eye. Cataracts can cause worsening of cataracts. History of gastric or esophageal irritation. Children, because we don't want to slow down their growth. Pregnancy and lactation. And then history of thromboembolic disorders or seizures can cause interaction with that, can cause increased risk for blood clotting and or excessive bleeding depending on what other agents it's being combined with. Drug-to-drug interactions. So interactions may occur with barbiturates, phenytoin, which is dilantin, and rifampin. All of these may reduce the effectiveness of corticosteroids if taken together. Estrogen and oral contraceptives may potentiate or make the effect greater if given with corticosteroids. Non-steroidal anti-inflammatory agents such as aspirin may increase the risk of ulcers within the GI tract. Diuretics, depending on especially on what type, can cause already a imbalance of certain electrolytes. And so depending on the type, it can potentiate potassium depletion and make someone more prone to having very low potassium, which is dangerous because potassium acts on the heart muscle to help with contractility and to actually make the heart beat. Live virus vaccines and toxoids, because the long-term or high-dose steroids may inhibit the antibody response. Bupropion can cause risk of seizures if given together. And then haloperidol or Haldol, increase risk of QT prolongation on the EKG. Knowledge check. Which is not a condition that can be treated by adrenal corticosteroids? A. Malignancies. B. Ulcerative colitis. C. Hypertension. D. Respiratory disorders. The answer is C. Hypertension. Hypertension can be a side effect of taking this medication, but it is not a condition that is treated by corticosteroids. Administration of adrenal corticosteroids. Prolonged administration of corticosteroids can cause suppression of the pituitary gland with adrenocortical atrophy, in which the body no longer produces its own hormones. Due to potentially serious side effects, corticosteroids are therefore administered for as short a time as possible and locally if possible to reduce systemic effects. Administration can be done through ointment application, so something like hydrocortisone. It can help kick down the inflammation in one specific area, such as on the skin. Hydrocortisone is something we use short term after, like a bug bite that swells or something that's in one specific area externally. Intra-articular injections. Injections are sometimes done into the joints themselves. So that is for people who have joint swelling. Maybe they had a knee or a joint replacement that's causing some extra inflammation and pain. They can get injections into that site itself, so it just stays kind of in that area. Ophthalmic drops for the eye, and respiratory aerosol inhalants. So corticosteroids, there are inhaled forms to help kind of loosen or reduce the inflammation and the tightness within the lungs during an asthma attack or something of that sort. Of course, there are also oral and IV injected, and so there's different that are not listed here, but this is some examples of administration that are not going to have such a systemic effect. Knowledge check. Which routes of administration can be used for corticosteroid therapy? Mark all that apply. A. Oral. B. Intravenous. C. Intramuscular. D. Nasogastric tube. The answer is A, B, and C. Debatably, they can also be given through a nasogastric tube, but the actual metabolism is more variable, so it's less likely that we'll use that route. But just be aware that there are different ways to give a medication. In the actual vein or PO is going to be, of course, a more systemic effect. And then there are the ones that we discussed that are more local, kind of act in one area at a time. As mentioned, long-term effects of corticosteroids can cause serious health concerns, and the following are the possible side effects related to long-term use. You will note that they are the same ones I listed as side effects on the previous slide, so I'm not going to read over them again, but just things to be aware of. The effect of these medications is this increased cortisol level, which is a stress hormone, and then the decreased immune response because it's kind of suppressing that response. So you can kind of critically think about all the things within the body that may impact. And then again, it's going to be on the same slide as the contraindications that will have all of the side effects. These are the same as the long-term dangerous effects of corticosteroids. Knowledge check. Which health conditions are not a long-term effect associated with systemic steroid therapy? Mark all that apply. A. Osteoporosis. B. Hyperlipidemia. C. Adrenocortical atrophy. And D. Stunting of growth in children. The answer is B. Hyperlipidemia. All of the other answers are long-term effects associated with systemic steroid therapy. Moving on to thyroid disorders. The thyroid is an endocrine gland located in the front part of the neck. If you look at the picture here, it almost looks like a bow tie. It's right in that exact same spot, or I like to think of it as the butterfly gland because of the shape. It's responsible for regulating the rate of metabolism. When thyroid levels are low, the pituitary gland releases thyroid-stimulating hormone, TSH. TSH promotes the biosynthesis and secretion of two bioactive hormones, thyroxine, which is T4, and triiodothyronine, which is T3. Thyroid agents can be natural or synthetic. So they can be given as a form that's naturally created in the body, or the more common that we see prescribed is Synthroid, which is a synthetic thyroid agent. The most common disorder that affects the thyroid gland is hypothyroidism. The term hypo, that prefix on the word there, means low, so low thyroid function, basically. Some symptoms of hypothyroidism, as shown here on the left: thinning hair, loss of eyebrow hair, puffy face. The gland itself is enlarged because it's trying to compensate and make more, but it's not making enough. Slow heartbeat, dry and coarse skin, constipation because metabolism's slowing down, infertility and heavy menstruation, carpal tunnel syndrome, cool extremities and swelling of the limbs. It can also lead to weight gain, poor memory, intolerance to cold, and feelings of tiredness or sluggishness. Hypothyroid conditions requiring replacement therapy. Cretinism, which is a congenital condition requiring immediate treatment. Myxedema, or adult hypothyroidism owing to a goiter, which is a growth on the thyroid. Hashimoto's thyroiditis. Pituitary disorders. Medications such as amiodarone and lithium, which can lead to hypothyroidism because of their impact on iodine, which is a mineral crucial to thyroid function. And then thyroid destruction from surgery or radiation. Levothyroxine is the most common replacement therapy. The initial dose is 100 to 125 micrograms, then adjusted based on symptoms, TSH level, and body composition. The TSH levels are drawn every 4 to 6 weeks until the dosage is stabilized and having the impact and desired therapeutic effect on the patient. On the other side, there is also hyperthyroidism. Hypo, remember, is low thyroidism, and then hyper, high. So hyperthyroidism means overactivity of the thyroid gland. This can be caused by Graves' disease, which is an autoimmune disorder where antibodies mistakenly attack the thyroid gland, and thyroiditis, inflammation of the thyroid gland. Orally administered radioactive iodine therapy is the most common treatment, and most patients are cured after a single dose. What happens in this case is that the person ingests radioactive iodine, which the thyroid gland will absorb, and then once it's in the gland, the radioactivity of the iodine will cause destruction of the cells. Surgery to remove all or part of the diseased thyroid is another permanent cure, but it's seldom used now because they typically go with this radioactive iodine ablation. So the cure is the destruction or removal of the gland through one of those treatments, and that will result in hypothyroidism. So then they're not going to have enough because you've now destroyed this gland. This results in most people with hyperthyroidism needing lifelong hypothyroid treatment after they've destroyed or removed the gland. There's a little graphic here about Graves' disease, which causes hyperthyroidism. People with Graves' disease, they'll usually have this kind of bulging eye appearance. They will have swelling over the thyroid. Oftentimes they have arrhythmias and tachycardia, rapid heart rate, nausea and diarrhea. Things are moving too quickly in the GI tract. Oligomenorrhea, where there is reduced menstruation. And then muscle weakness and tremor. You also might see headache, excessive weight loss, nervousness, and emotional instability in a patient with Graves' disease due to that overactivity of the thyroid gland. Hyperthyroidism agents. Methimazole and propylthiouracil, PTU, are both agents used to treat hyperthyroidism, used to relieve the symptoms in preparation for surgical or radioactive iodine therapy or for those who are not candidates. Methimazole is typically the first-line treatment because it has less negative impact on the liver. It's important to note that neither of these are helpful for the treatment of hyperthyroidism associated with thyroiditis. because this condition is due to the release and not the overproduction of thyroid hormones. Side effects and caution: rash, urticaria, which is hives, and pruritus, itching. That can be treated with antihistamines. Can cause an abnormal sense of taste. Can also cause blood dyscrasias, especially agranulocytosis. Cautions: prolonged therapy is seldom used for these drugs. Be extra cautious in patients over the age of 40. Pregnancy and lactation. And hepatic disorders. It's actually a black box warning with PTU because, again, this can cause liver dysfunction. And if you already have a liver disorder, that's going to be very dangerous. Drug-to-drug interactions that may occur. So other drugs that are known to cause agranulocytosis that can cause a potentiating effect. And then excessive iodine intake or drugs containing iodine, such as amiodarone, because that will lead to decreased efficiency. Talking about your hypothyroid agent, specifically levothyroxine, Synthroid. Toxic effects: it can lead to palpitations, chest pain, tachycardia, cardiac arrhythmias, and increased blood pressure. Nervousness, difficulty concentrating, tremor, muscle weakness, headache, and insomnia. Weight loss, in spite of increased appetite, diarrhea, and abdominal cramping. Intolerance to heat, fever, and excessive sweating, easily fatigued. And menstrual irregularities, as well as exophthalmos, which is that those bulging eyes. So think of the toxic effects of taking this synthetic thyroid hormone. Think of it like the Graves' disease, right? It's similar to the presentation of that because the toxic effects are, if it builds up and you have now too much in your system, then you're looking at those hyperthyroid symptoms. Conditions and cautions: cardiovascular disease, including angina pectoris, chest pain, myocardial infarction, which is a heart attack, and hypertension. Older adults, because it may precipitate dormant cardiac pathology, so it may kind of cause something that is not currently acting up within the cardiac system to act up and to cause a problem. Adrenal insufficiency. We need to make sure corticosteroids are given in the case of adrenal insufficiency if we're giving levothyroxine. And then somebody who is a diabetic will need close monitoring of their blood sugar while on Synthroid. Some drug-to-drug and drug-food interactions. Food can diminish absorption by 50%, so this drug is taken on an empty stomach. So Synthroid is always taken on an empty stomach, oftentimes first thing in the morning. The potentiation of oral anticoagulant effects, if added after warfarin therapy is stabilized. So it can, if you have warfarin, if you're taking, which is an anticoagulant or a blood thinner, if you are on a stable therapy of that and then you start Synthroid, it can cause the therapy to no longer be stable. It can cause it to actually be overactive and have too high of levels. Insulin and oral hypoglycemics, dosage adjustment may be necessary. Potentiation of adrenergic effects, so medications such as epinephrine, if there's going to be this excitability and we're adding that to Synthroid, we need to watch closely. Estrogens and oral contraceptives can lead to decreased thyroid response. Amiodarone. Amiodarone contains about 37% iodine by weight, but can cause either hypo or hyperthyroidism, so monitor for changes in thyroid function. Aluminum, calcium, iron, magnesium salts, chromium, and sulforaphate. All of these lead to decreased absorption, should be spaced several hours apart when taking if possible. And then soy products can lead to a decreased response of Synthroid as well. Knowledge check. A patient with Hashimoto's thyroiditis is prescribed levothyroxine. Which signs or symptoms indicate drug toxicity? So this was what we covered on the last slide. Mark all that apply. A, tachycardia. B, hypoglycemia. C, weight gain. D, excessive sweating. The answers are A and D, tachycardia and excessive sweating. Can also lead to excessive weight loss. Next, we will be talking about anti-diabetic agents. It's important to have an overview of what diabetes is. So, diabetes mellitus, DM, makes up a group of hormonal diseases characterized by impaired metabolism of carbohydrates, fats, and proteins that results in elevated levels of blood glucose. Diabetes is classified as type 1 or type 2. So, what happens in the case of somebody who has diabetes is a little different for type 1 or type 2, but essentially the pancreas, which is responsible for the hormone insulin, either does not create any or does not create enough insulin, or the body becomes resistant and is unable to use the insulin the way it's intended to be used. What insulin does in the body is it uses the food that we're ingesting, specifically glucose and carbohydrates, which break down into sugars. It takes that into the cell, and insulin allows it to be used for energy. So if somebody has diabetes, they're not able to effectively use those sugars for energy, either because they're missing the insulin needed for it, or because the insulin is just sluggish, it's not working the same way because the body's becoming resistant. And so they'll have high blood sugars when they check, but despite having high numbers, that's because the sugar's building up in their bloodstream, but it's not able to actually be used for energy. So just to kind of give you an idea of what we're talking about when we're talking about diabetes. For type 1 diabetics, the characteristics, the age is young. They're usually diagnosed under 35 years old and oftentimes even in childhood. The onset is rapid, leading to ketoacidosis, because in type 1 diabetes, the body cannot actually produce any insulin. Ketoacidosis is a serious complication that occurs when the body does not have enough insulin, because if the body cannot break down sugars, it will start to break down fat for fuel, and that produces harmful substances called ketones. Those will build up in the blood and make the blood acidic. It's a very dangerous medical emergency. Body composition, typically type 1 diabetics are not obese. Oftentimes, actually, you'll see that they are very thin. The body in type 1 diabetes cannot produce insulin. And the way that this is managed is by insulin injections with diet and exercise. Type 1 diabetics are often the ones that you will see with a little patch on the arm or leg known as a continuous glucose monitor to keep a kind of level of their sugar known at all times. And then oftentimes type 1 diabetics will also rely on a insulin pump, which is kind of acting as its own pancreas. Since their pancreas can't produce any insulin, the pump will sit outside the body. It will have a small needle injected kind of right under a little probe right under the skin. So it's monitoring levels of blood sugar and giving insulin as needed, the same way that the pancreas would if it were working. Management. Oh, we already talked about management. Okay, so type 2 diabetics, on the other hand. Type 2 diabetes is typically diagnosed when people are older. The onset is more gradual. There's no symptoms in the early stages. And oftentimes, for the most part, the body composition is going to be more obese. So the cause of type 2 diabetes is insulin production is normal or altered to some degree, but the body cells are resistant to insulin. So sometimes there's a little bit less insulin produced, but typically it's the same production, but the body cells become resistant due to being overused, due to excessive consumption of glucose, carbohydrates, etc. Management for type 2 diabetes: oral or injectable non-insulin medications with insulin injections only if needed, and then diet and exercise. Let's talk about some different types of insulin that might be given to a patient with diabetes. There is Aspart or Novolog, Glulisine or Apidra, and Lispro or Humalog. These are all considered rapid acting. Rapid means that it's going to start working fast, but it's also usually going to have a less duration time. So the onset of rapid insulin is 10 to 30 minutes. The peak is 1 to 2 hours, and the duration is 3 to 6 hours. Rapid is usually given right before a meal, or if the patient is about to start their meal, it needs to be pretty close to that time because it's going to have that faster peak when the medication is working the most strongly in the body. We want that to be to help break down the food that's getting ingested in that moment. Another preparation is regular. So it's short acting, or we call it regular insulin. Trade name is Humulin R or Novolin R. So the R is for regular. The onset is 30 to 60 minutes. The peak or time of maximum efficiency is 1 to 5 hours. And the duration is 6 to 10 hours. Next, we have the intermediate acting, which is isophane or NPH, Humulin N or Novolin N. So again, these are the same names, but then there's the N afterwards. So think of that as N for intermediate. Onset is 1 to 3 hours. Peak is 6 to 12 hours. And duration is 18 to 24 hours. So it can cover you almost up to a day. Long acting, glargine, which is Lantus or Basaglar. 1 to 2 hours is the onset. No pronounced peak. And it the duration can be up to 24 hours. A lot of times with insulins, you are going to take a mixed insulin, as you'll see down at the bottom, or you will take 2 different types. So the other ones are ultra long acting. I don't see these used often. Detamir, Glargine, Degludec, Levemir, Tresiba, and Toujeo. I've never even heard of that. The onset is 1 to 2 hours, no pronounced peak, and can lead to improved glycemic control up to 24 hours with a more gradual release. Typically, I'll tell you, Lantus is one that we'll see more often, as well as regular insulin, Novolin or Humulin R, and then that rapid acting Novolog or Humalog. There are mixtures of NPH and regular, such as Humulin Novolin, NPH and Lispro, Humalog mix, or NPH and Aspart, Novolog mix, and the onset, peak, and duration are all listed here. What I mean when you might take multiple insulins is somebody very well may need more control over their long-term levels, and so they will take a certain number of units of Lantus, and insulin, just so you know, is measured in units. That's how we give it. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 units, not mLs or milligrams, units. We may see somebody who takes Lantus maybe at night, and they'll take 10 units, and that will help cover them over 24 hours. But then they may also take a regular insulin or even a rapid or shorter acting 3 times a day. So that will help to control for spikes from meals, etc. Knowledge check. Which insulin preparation has no peak with a duration of up to 24 hours depending on the dose prescribed? A, Novolog 70/30, that's one of those mixtures. B, Aspart, Novolog. C, Glargine, Lantus. Or D, isophane NPH, Humulin N. And the answer is C, Glargine or Lantus, which again is that long-acting 24-hour insulin. It's important to know that people with diabetes can suffer from both hyperglycemia, high blood sugar, and hypoglycemia, low blood sugar. They can also have swings between the two. We call this having labile blood sugars, especially if they're relying on insulin, and maybe, let's say they took 5 units of insulin and then they started eating their meal and they were like, oh, I'm not really that hungry. Well, they already put insulin in their body that's going to be working regardless of if there's food or not. And so that can cause their levels to drop too low. So it can really be a delicate balance in trying to manage sugar levels. Symptoms of hyperglycemia, high glucose, include dehydration, anorexia, and unexplained weight loss, because again, even though their sugar is high, it's not being able to be used, and so the body starts to go into starvation mode. Polyuria, which is frequent urination. Fruity breath, as those sugars build up in the body, it can cause a sweet smell to the breath. Lethargy, weakness, flu symptoms, and even coma if untreated. Vision problems, and ketoacidosis, where the body starts breaking down fats. Treatment is IV fluids. It helps to correct the ketoacidosis and push things back into the intercellular space where they belong. Regular insulin and correcting those electrolyte imbalances. There is this kind of homeostasis within the body, and there's also this osmotic pressure between the cells and the extracellular space that can be imbalanced based on the high level of glucose circulating in the bloodstream. Hypoglycemia, signs and symptoms: increased perspiration, pallor, which is pale coloring to the skin, hunger, nausea and vomiting, irritability, confusion, or sudden unexplained bizarre moodiness or behavior, tremors, weakness, headache, hypothermia, low temperature, or tingling of the fingers, blurred or double vision, tachycardia and shallow breathing, loss of consciousness and convulsions if untreated. Hypoglycemic reactions in older diabetics may also mimic a stroke. So if we have a patient who comes in for stroke-like symptoms of confusion or weakness, we will go ahead, every stroke-like patient, actually, we do a blood sugar check as the first thing, just kind of an automatic when they walk into the ER. Or if, they go through the paramedics, they do the same. Treatment for hypoglycemia: administer orange juice, honey, or other foods to bring up the glucose, followed by something with protein to make it a longer lasting effect. And if the patient is comatose, unable to eat something, we'll administer 50% dextrose or glucagon, which can be given intramuscularly. This slide talks about other medications that can be given to diabetics besides insulin, which is just giving the hormone itself. These are your oral hypoglycemic agents and your injectable non-insulin agents. There is an upcoming slide that's going to go over each of these and how they work in the body. But what I want you to be aware of is that typically with a type 2 diabetic especially, we will start with an oral agent. It's much better for patient compliance if we start them on a pill versus telling them they have to inject themselves every day. Sometimes it will work for a long time. Sometimes it will work in the short term and they end up having to also end up on insulin. But we a lot of times will start with either an oral hypoglycemic agent or one of your injectable non-insulin agents, because even though it's a shot, it lasts for longer. So example, your GLP-2s, they're only given once a week. So it's easier than a daily shot of insulin. Knowledge check. Which are signs or symptoms of hyperglycemia? Mark all that apply. A, dehydration. B, fruity breath. C, shallow breathing. D, sudden moodiness. The answer is A and B, dehydration and fruity breath. The other two are symptoms of hypoglycemia. Case study. A diabetic patient presents to the emergency room. The spouse stated that the patient was fine when they first got up. The patient took their insulin, had a shower, and then had a cup of coffee. About 2 hours later, the patient began to experience blurred vision, tremors, nausea, difficulty speaking, stumbling around, and slurred speech. After initial testing and evaluation, the physician diagnosed the patient as having a blank episode. A, hypothyroidism. B, hypoglycemic. C, hyperglycemic. D, hypertension. Looking at the context clues of our question, it's a diabetic patient, so I'm assuming that the imbalance will be in their sugar. That right there eliminates A and D. Then I think this patient took their insulin, had a shower, and then had a cup of coffee. I don't see any food was ingested. Were they taking short-term insulin or fast-acting, rapid-acting? We don't know. So I'm automatically thinking we're going to be dealing with a low. And then we look at the symptoms, and that kind of confirms our suspicion. So the answer is B, hypoglycemia. Type 2 diabetics, as I mentioned, they have this resistance to insulin. So the insulin is produced but not used effectively, combined with sometimes a deficiency of insulin as well. Frequently, it's necessary to combine diet and oral anti-diabetic agents. The medications are not a substitute for dietary management, so we also do need to do a lot of patient education about eating a low carbohydrate diet and what type of foods will spike sugar up, etc. But These are the agents that I mentioned on the previous slide. We're going to now talk a little bit more about the categories and how they work. So your biguanides, such as metformin, work by decreasing hepatic glucose production and enhancing insulin uptake in muscle tissue. These can be used in combination with some of the other categories and also can be used in combination with insulin. But metformin and biguanides are the preferred initial first-line monotherapy, meaning if we're only doing one therapy, we'll start usually with metformin. Some side effects are GI effects such as diarrhea, nausea, vomiting, bloating, flatulence, metallic taste, anorexia, and weight loss. These are generally mild and resolve during treatment, and if taken with food, this will minimize the epigastric discomfort. The next category is your sulfonylureas, chlorpropamide, and tolbutamide. These work by increasing insulin production from the pancreas and improving peripheral insulin activity. Side effects are also GI distress, which may subside when the dosage starts to regulate. Dermatological effects such as pruritus, rash, urticaria, or photosensitivity. Hypoglycemia, especially in older adults, so they must make sure they're eating consistently while on this medication. And weight gain and water retention. The next category is your alpha glucosidase inhibitors. Acarbose is the example they give here. These delay digestion of complex carbohydrates and subsequent absorption of glucose, resulting in a smaller rise in blood glucose concentrations following meals. So it kind of allows things to more slowly be digested and able to be utilized by the system. So it slows down this sudden onslaught of glucose into the system. These can be used as a monotherapy or part of a combination regimen that includes insulin, metformin, or an oral sulfonylurea. Side effects, these also have a high rate of GI effects, which tend to diminish over time. Take at the start with the first bite of a main meal, and can also cause elevated liver enzymes, dose-related and generally asymptomatic, and can be reversible, but if you are on one of these, they will be monitoring your liver enzymes. Next, we have your incretin therapies, which are injectables. The examples given are exenatide and semaglutide or Ozempic. These work by decreasing glucagon secretion, delaying gastric emptying time, and decreasing food intake because you have this increased sense of fullness, and this results in weight loss. Side effects are nausea or vomiting, diarrhea, dyspepsia or indigestion, gastroesophageal reflux, injection site reactions, and hypoglycemia. We have your meglitinides, your nateglinide, and your repaglinide. These work by stimulating the beta cells of the pancreas to produce more insulin. They can be used as monotherapy or in combination with metformin. They have the same GI effects, hypoglycemia, and can cause initial weight gain. And these also have the added risk of upper respiratory infections, sinusitis, arthralgia, and headache. You have your thiazolidinediones, pioglitazone, and rosiglitazone. These work by lowering blood glucose because they decrease insulin resistance and improve sensitivity to insulin in muscle, liver, and adipose tissue. Can be used as monotherapy or concomitantly with other agents. Side effects of these are a little bit more drastic: weight gain, fluid retention, edema, upper respiratory infection, sinusitis, pharyngitis, and headache, myalgias and atypical bone fractures, anemia and hypoglycemia in combination with other agents. So you can imagine the meglitinides and the thiazolidinediones are not categories we're going to use as frequently just because their side effects are so much more and more dangerous than some of the others, and metformin is usually going to be your first-line therapy. Last, we have sodium glucose cotransporter 2, SGLT2 inhibitors, which are also injectable, canagliflozin, empagliflozin, and dapagliflozin. These work by decreasing the reabsorption of glucose in the kidneys, essentially lowering glucose available to the body via excretion. can be used as monotherapy or in combination with oral medications. Some side effects are vaginal yeast infection, urinary tract infections, and increased desire to urinate. Knowledge check. Which drug is the preferred initial first-line monotherapy for diabetes? A. Acarbose, B. Glyburide, C. Glimepiride, D. Metformin. The answer is D. Metformin. Self-assessment. Remember that the self-assessment is your chance to make sure that you kind of got the most important information from the slides. Always go back to your book because that is going to be the most detailed information. Self-assessment question 1, what is the pituitary gland also known as? 2, what are the signs and symptoms of hypoglycemia? 3, what are the onset times of rapid, intermediate, and long-acting insulin? For that question, I highly recommend you go back to that slide and have a pretty good knowledge of rapid versus intermediate versus long-acting, because that's going to be something you will be working with quite a bit in your career, and it will also be testable for both quizzes and the final. Thank you for listening. This has been Chapter 23, Endocrine System Drugs in Essentials of Pharmacology for Health Professions, 9th edition.